Okay, so actually what I was telling you that whatever happens in operation theater, it is related to blood pressure, pulse, respiration in the form of respiratory rate or rhythm. Okay, and you are having oxygen saturation and tidal CO2. Okay, and the heart rate, whether it is tachycardia or bradycardia. Okay, and another thing which is related to a cardiovascular system is cardiac output, uh, and ECG. In ECG, you are finding any problem in the rhythm. Okay, and in cardiac output, there are changes, and you can see in the circulation. Okay. So actually, this is just a revision of what we have done before. So just a second. So actually, that is how I we just approached. Yesterday we did arrhythmias, okay, and before that we discussed some points about temperature changes, uh, respiratory changes, maybe cause of upper airway obstruction or lower airway obstruction, okay, and central problem. So if you just can review the previous two discussions, it will be easier for you to correlate what we will be discussing today. Okay, so we discussed about the problem related to conscious level. So we just did differential diagnosis, how to approach it, and it may be in the form of altered level of consciousness or in the form of delayed recovery or post-operative delirium. Okay, so this is what we have done before. Okay, we have also discussed never events in anesthesia, which are related to wrong, like anything which is unwanted. It may be related to wrong-sided block, wrong-sided surgery, and wrong blood administration. And if you extravasate, you did not come to know the line, the patient was covered and the IV line was dislodged and the fluid was giving, and when you the patient awake, it is full swollen. So how to manage it, and intraarterial, this is what we have already done. Okay, so today what I was thinking to discuss something related to positioning. Okay, so see. So whenever we discuss about positioning, like positioning may be supine. Okay, it may be prone, it may be Trendelenburg, it may be reverse Trendelenburg, it may be lateral. Okay, this is positioning usually related to the surgery, but there are certain anesthesia maneuvers in which you do a slightly different position, like for example, there is a position which is called as ramp position. Okay, rapid airway management position. Okay, so in that position, what you do, actually I will just show you the picture of ramp position just to show you. So this is what is ramp position. Okay, so in which you elevate the head in a way that the external auditory meatus comes at the level of sternal angle. Okay, here is a sternal angle, the sternomental junction. Okay, and you elevate in a way. So what is the advantage? The advantage is to facilitate the airway, like there will be better visualization of vocal cords when you are doing laryngoscopy, and it also helps in managing the airway, especially in obese patient and pregnant patient. Okay, it increases FRC. It makes, because whenever we intubate, there are actually we have to handle with three angles. One is oral angle, other is pharyngeal angle, and the third is laryngeal angle. Okay, like when you, there is one oral angle, there is one pharyngeal angle, and sorry, this is pharyngeal angle is usually like this, and one is oral angle. Sorry, laryngeal angle. I will just draw it again. This is oral angle, this is pharyngeal angle, and this is laryngeal angle. Okay, so you are looking at it. So when you do this jaw thrust and chin lift, or you make this sniffing position, actually you align these angles. Okay, that's what you do when you are doing laryngoscopy. So the ramp position, when you are doing it, it helps in facilitation of laryngoscopy and intubation. Okay, so this is what is related to ramp position. Just a second. Okay, so another position which you do when you are passing CVP is, okay, especially if you are doing CVP in internal jugular. Okay, so usually what you do Trendelenburg, and you put Trendelenburg position will increase the venous return, and it will just make a little engorgement in the internal jugular vein. So this is, and you put a shoulder, a roll under the shoulder. So it is easier for you to have visualization of when you are using, for example, ultrasound, then actually sometimes it is not as important as you are doing it as a landmark technique, blind technique. Okay, so this is one thing. Another thing is that if the patient, what you extra you do is you need to give some fluid. If the veins are collapsed, you might need to give some fluids to facilitate this this one central line placement. Okay, so Zishan, you have just joined. So I have just started regarding to positioning. Okay, so the normal positioning which everyone knows, I'm just discussing a little bit extra than that. So what special position you need for central line, and we have just discussed ramp position. Okay, so you know about ramp position, so just to keep you intact. And then what else position you do? Any other special positioning which you do for anesthesia facilitation? Like you make sitting position for central neuraxial block, for example. Okay, and actually the theory is that you have to just bend down a little bit. Okay, so that you are able to the gaps between the vertebra are improved. So there are so many ways to do it. Some people just put a pillow in between the like when they are making the position, they put a pillow on under the hands of the patient, and to facilitate the position. So this is the sitting position which you do for central neuraxial block. Any other positioning which you can recall, Zishan, related to anesthesia procedures or anesthesia? If you have suddenly regurg, what you do?
So head down,
and
lateral.
Okay.
We also do head down for putting the necklines.
Yes, necklines also with putting a roll under the shoulders to facilitate. Okay, so when regurgitation occur, you do like this. Similarly, if there is element of venous air embolism, you also do the same thing. Okay, you do the head down to increase the venous pressure. Okay.
So, but actually, it's not only head down. According to surgery, we have to keep the heart above the surgical level.
Yes, yes. Actually, in venous air embolism, you are blocking, as we discussed yesterday, that it is mainly related to the whenever we are discussing about venous air embolism, majority time it is related to neurosurgery. Okay, it can occur in other surgeries as well, but usually the first thing is we are discussing with reference to neurosurgery. So in neurosurgery, when you increase the venous pressure, actually you decrease the chances of more air embolism. Okay, and venous air embolism in a normal patient and venous air embolism in which there is intracardiac shunt. Okay, so that is
Yes,
more critical. If you have a patient with right to left shunt, it becomes very dangerous. Okay, so it is called as, what is the terminology called as? Paradoxical air embolism.
paradoxical air embolism. Yes.
Okay, so these are a few extra things. Now we will be discussing the main, but actually you performance of, you do a special positioning for nerve blocks. Okay, for the, as I discussed, CVP. There is a position which we do for arterial line. What we do in for example, if you are doing a wrist, so you slightly put something.
Wedge.
Yes, but just put something
Wedge.
under the hand so that you extend. But the problem, remember one thing, you don't overstretch it, because if the
Yes.
hands are mine don't, I'm sorry for very terrible drawing, but if you put some, if hand is too much extended, then the pulsation will, you will not be able to feel pulsation too much. So if you are overstretching it, it can even create problem. Okay, so do it, usually put a tape here, just put a tape here and put something under the wrist. So this is the hand. So finally there is something I'm able to draw. I'm very bad in drawing, so no, please, apologies for that one. Okay, so we do for the lines, for the blocks. Okay, and to tackle any emergency. Okay, and as I told you, for facilitation of airway. Okay, and even proper position we do for clearance of airway. Okay, and to improve the increase FRC. Okay, so actually another just the one thing, just with reference to needle positioning. Okay, there is a cutting edge. I will just try to.
Bevels of the needle, sir. Are you
Yes,
talking
bevel.
about bevels of the needle?
Yes, bevel of the needle,
Yes,
and
sir,
even,
there are short bevels, there are long bevels.
Yes, I just want to tell you another
Cutting
thing,
and non-cutting.
that if, for example, if you are having this cutting needle, okay, and even when you are doing this for central neuraxial block, or even you are doing for arterial line or central line, try to put it in like not in this angle. You have tried to put it in 90-degree. So if you are just maybe I will not be able to explain in a better way in this one, but actually you don't have to go like this. You have to make it a little like, if this is the edge, this is the needle. Okay, you try to twist it. Okay, so it becomes, this cutting side becomes on the side. When you are entering in, even
Yes.
with the spinal, it is better to make it in one side, this cutting side.
Yes, sir.
Okay, and then
So
you
I can
enter.
explain it better.
Yes.
you see the fibers of the of the ligamentum flavum go longitudinally from above to downwards. So if
Okay.
we have turned the needle, the bevel of the needle to
It will pass
on
through it.
the sideways, the fibers won't be cut, but they would be
Yes.
separated, and
Separated.
the
Okay.
needle won't cut the fibers. Yes.
I hope all some other people understand this, that you they have to twist, turn, and then. But there is another point. When once you are enter in the space, you have to turn it back. Like when this cutting edge was this side, you have to turn it back. So it should be coming up, because what will be the problem? The problem is that if the needle direction is on one side and you inject it, the spread may be partial, it patchy. It is one of the reason for, and if, for example, if it is in down direction, so because it's a hyperbolic solution, it will go more in the downward direction. So if you are entering it, try to make it on one side. And then when you are entering it, you have to twist it up. Okay. So what is they made it the hole at that place. If you see the spinal needle, you will see that the place from which you insert this plunger, this is on the top side. So once you are inside, you can identify by seeing the direction of the plunger you are pulling it out. Okay. So I hope I am able to make you understand a little bit, because if you make it down, up, down, or in sideways, there are chances of inadequate spinal. Okay. So this is one point I just wanted to tell. Similarly, for arterial line, this is actually some practical aspects. So if you are facing problem in even in arterial line, sometimes some people say that it is better you just when you are doing with Seldinger technique. Yes, Ishan?
Sir, I didn't get it. I get it that if the bevel is downwards, the spread of these our subarachnoid drug won't be go up to the level which we want. But
Mhm.
if it's sideways
Mhm.
and it's in the subarachnoid space, then why would it be
Yes, it
on one
can.
side only?
It is one of the factor for partial block. Okay. It is better you make it upside. Okay, because you want it to spread in one direction. Because you are inside, there are septa. Sometimes there are septa. Okay. This is, so it is better even if you are putting epidural catheters. That's why we make it up, because if you make
Yes,
it
sir.
down, the epidural catheter go in one direction. So that's why even in placement, while placing epidural, it is suggested to make it up so that it will go in the upward direction and in center actually. Okay. So if you are making it in one direction, there is a chance of patchy block. Actually, there are so many ways to avoid this problem. It is better to do barbitage. Barbitage is very gradually, slowly aspirating it, mixing it up. And if you want to have the effect quicker, actually, this is a technique which people used to do it, mixing it up. Yes, but the problem is that you don't have to over aspirate it with high pressure, especially if you have a
Yes.
patient already having high CSF pressures and you do aspirate with high pressure, there are chances of coning. Because what is PDP? In the PDPH, you are this dural puncture headache, the theory is the same. And this is the reason that you don't give spinal or do lumbar puncture if you have a high signs of high ICP. Okay. So you don't have to aspirate with very high pressures. You have to use, that's why it is recommended to use 3cc 3cc syringe for the administration of spinal, okay, rather than 5cc, because in 5cc you need more pressure. There are more chances of creating more pressure unintentionally. Okay.
Mhm.
So this is the point.
Actually, I've experienced this partial block or right or left. Um, my
This is
practice is keep the
one of
bevel
the,
on the side.
but one of the reason is this. Okay. One of the reason is this. So actually anatomy is always my weak point. So I am not very having good concept about it, but I can just explain you even with the experience that you have to make it up. Okay, so we will just discuss about positioning in some detail, because usually the steps which are when you create the position, this is a critical step. And after that, if you don't make it safe, then there are some problems. And when you reverse it, there are issues. Okay, so you have to keep these three things in your mind, that any position when you are creating it, there may be some problem, and then you have to keep the safety. I will just discuss shortly that what do you mean by it, and then you are reversing it. Okay, so there are problems whatever you are happening, and there will be some common things. There will be some problem in the physiological system, like for example cardiovascular and respiratory. Usually, even if you are doing lateral position or supine position, or any position, the main systems which will be affected will be cardiovascular and respiratory system. Then there is if there is some endotracheal tube, so endotracheal tube may be dislodged, or any lines may be dislodged. So this is another thing. Then it is related to joints and pressure points. Okay, this, and another thing is nerve injury, nerve pulse, nerve involvement. So usually you can just classify in these 3-4 steps, and then you can see in each position what happens. Okay, for example, if we just see lithotomy, so in lithotomy position, you have to preoperatively, you have to see what is the joint limitations, because if there is problem with the hips or knee, and you try to overdo it, and especially if you are doing it in under spinal, you gave the spinal, there will be no pain, or maybe you are able to, if you are dislocating. So it is better to evaluate in that regard as well. Okay, then when they are making, the poles should be in equal positions. Okay, and then both limbs should be positioned together, not like you are making it one and then you are bringing it the other one. So this is a big problem. Okay, so with related to physiological effect, as I told you, when you combine lithotomy with Trendelenburg, so the effects are even pronounced with reference to physiological effects. So there is decrease in FRC. Okay, and what happens in the cardiac output initially? What happens when you
Output increase, sir.
Yes, so actually there is increase, like you can say auto transfusion. Okay, so there is auto transfusion of it depending 200, 300 mils of or 500 mils of fluid. So if normal patient may tolerate it, but otherwise, similarly, because related to FRC and related to venous return. Okay, so this will happen. Then if you don't position carefully, what nerves can be involved in lithotomy position?
It's either common peroneal or superficial peroneal. I'm forgetting it.
Common
correctly.
peroneal.
Common peroneal.
And what else? What about femoral?
Femoral can be stretched
If you are
because
doing
there's no
flexion,
pressure on.
flexion, because of flexion, when you make it, there is a flexion. Okay, so there
On the
is
knee.
involvement
Yes.
of femoral nerve. Okay, and what about obturator nerve?
You can add me, sir.
Yes, anatomy hurts me. So anyways, obturator nerve can also be involved, but mainly these things happen. Okay, so similarly, when you reverse it, there is pooling. Okay, so pooling of blood, so there may be decreased cardiac output and decrease blood pressure. So this may be not significant in a normal individual, but in a patient with limited cardiac reserve, this may be a significant thing. So lithotomy position, okay. And as I told you that if patient is intubated, okay, there may be chances of endobronchial. Okay, it can occur. because the abdomen, there will be increased pressure. Especially this is true if you are there adding it with Trendelenburg, like lithotomy plus Trendelenburg. Okay. So usually these are the things which are related to lithotomy position. So usually what are the surgeries in which they are doing it? For TURP, for any endoscopic urology, okay, and gynecological procedures, anal procedures, okay, obstetric, DNC and delivery. So this is usually the positioning in which surgeries in which they are doing this lithotomy position. Okay, so you have to be careful about careful padding to avoid nerve injury, to avoid these problems. So what about reverse Trendelenburg? What will be the effects? There will be pulling again. So as I told you, the effect on CVS, there will be pulling and there may be hypotension. Okay, and actually because
Endobronchial also, sir.
I'm sorry.
Tube can go endobronchial.
No. This occurs in Trendelenburg, not reverse Trendelenburg.
Dislodgement can occur, yeah, discontinuation also.
Yeah, because circuit will be stretched. Okay.
Discontinuation of circuit.
And actually, you know, sometimes, for example, this is head side and this is foot side. In some tables, they will be doing like this. Okay. So this is also called reverse Trendelenburg. But in some time, because maybe this bed is broken, like there is option of, so they are doing it like this, for example. Okay. So that occurs, for example, in thyroid. Okay, in the ENT, when they are doing this transsphenoidal procedures, they make like a position like this sinoscopy, FES. Okay, so thyroid surgery they do like that. So actually, truly speaking, if because some beds there will be not option of breaking it, so whole of the bed is going up or down, but in some cases it will be like this. Okay, so similarly, so there will be if increase FRC will improve actually. Okay, but what else problems can occur? As I told you, there may be hypotension and there are chances of venous air embolism. Okay, what else? Tube dislodgement, circuit stretching. Okay, I think this is it. And when you are doing Trendelenburg, okay, in Trendelenburg the reverse occurs. Now endobronchial intubation can occur. Okay, what else? There is maybe rise in ICP. Okay, what else?
Sir, there is edema, cerebral edema, as well as edema of the airway, eye and airway and tongue also, in cases of then 2-hour surgery.
Yes, actually they are doing Trendelenburg when they are doing laparotomy. Okay, sometimes they are asking to make it head down, head down. Even there are so many jokes. They are making the head layer like this and they are saying, can we do it more? You might have seen pictures like that. So they are doing it just to facilitate their surgical field. Okay, so but remember one thing, that you have to take care, and if the patient has some problem in some neurological problem, this may be a thing to limit it. And actually there is a way that you make if the table is able to break, okay, you can make selective, and there is another way that you put a pillow under the shoulders. Okay, so the head is a little bit elevated, though it is down, but still somehow you are able to elevate a little bit of head side. So this will just decrease some of the effects which they are doing it. Okay, so this is about Trendelenburg. Okay, what about the most important position which we face is or dangerous to is prone. Okay, so in the prone position, actually there should be adequate number of people who are able to do it in a proper way. Okay, and there may be chances of joint dislocation, neck injury. Okay, so you have to make your hands in a way that you are covering the spine area. Some people only hold the head, which is wrong. You have to keep your hand in a way that you are supporting the neck. Okay, so that head is not twisted or angled on it. Okay, and then the tube, endotracheal tube, should be fixed very nicely, because I will just discuss with you that, for example, okay, no problem. We will discuss this scenario first, that the endotracheal tube is dislodged in prone position. What will you do? Yes, Ishan.
There are two options. Either we have to make the patient supine and then reintubate, or we can put an LMA.
Just a second. If this question is being asked as a consultant, you can answer in this way. But because you still have to pass the exam, so I'm expecting that you are calling for help. Okay, you have to inform the surgeon. Okay, and then whatever you are telling, now you can tell whatever you are telling. You are missing the basic, because in the exam they will have it will be written in the key. So if you are not telling, you are losing your marks and losing your impression. Okay, so don't forget about it. Then what you will do?
So we can put an LMA, or we can
be realistic. Be realistic. First thing what you should be doing: mask ventilation.
Mask ventilation.
Okay, and then you will calling for help, and then you will try to put, actually among you will say supraglottic. It is better you say supraglottic, because it is easier to put I-gel than LMA. Okay, the I-gel, because its placement is relatively easy, it is firm, so there are more chances of. But if you forget to tell mask ventilation, okay, this is against the algorithm, against the safety. First of all, actually you will do the first thing first. Okay, you will try to just do the mask ventilation, and then you will try to put supraglottic. Can you say intubating LMA?
Yes, sir.
Sir, it will be more helpful, I guess.
Okay, what about fiber optic?
Yes, fiber optic is also.
Okay.
At this time?
No, once you are stabilized, once you will not try to start fiber optic without making mask ventilation. Okay. So you have to maintain the mask ventilation, and then you are going for fiber optic. Sorry, LMA, LMA or I-gel, and then you can consider. And at the same time, you are evaluating the situation, and you may flip the patient. Okay, according to the scenario. For example, if there is a spine surgery going on, and you have open spine in prone position, and the tube is dislodged, what will you do? It's a hard situation. Okay, it's flipping is not so easy, and because there is a special table in which there is a hole in between, so it's not so easy to flip the patient. Okay, so the other question which may be asked, you have a cardiac arrest in prone position, what will you do?
CPR can be done in prone position also.
Okay, so specifically if you are doing spine surgery, so you can do in the time you are arranging for it, the flipping or anything, you can continue the CPR from the prone position, and if you fail, you can ask the surgeon to do open cardiac massage.
Is it possible to do? Is it possible to do CPR from prone position? I haven't ever seen in my life.
I wish you never see in your life. Okay.
Inshallah.
But actually you will be surprised that this question was asked to us in Irish fellowship exam. And I was surprised that I never ever even thought about this question before. Okay.
This is
So
done even in Browning.
yes.
And
So actually you can, you pray that you don't face this scenario, but in the exam, the answer is like that like Zishan is telling that you will start the CPR in the prone position and you will reevaluate. And this is an option if you are losing the patient, then especially in scenarios of spine surgery. Okay. You can, because any other surgery, you can flip the patient easily. Okay. But if you have open spine, patient is not in a position that you can flip, then one of the option is to open the lungs, open the pleura and do the direct cardiac massage. Okay.
but even that would require flipping the patient.
No,
We can't
can do it
cardiac
from-
massage in prone
they will
position.
they will cut the rib and enter the heart.
Hmm.
But
This is
the
theoretical.
heart is
This is
interior. Yes,
theoretical.
sir.
This is only theoretical. I wish that you never, any of our colleague ever see this. Okay. So this is in the exam scenario, if they are asking this question, you can tell this question. Okay. So some other points which you should be knowing, that there are chances of breast injury, genitalia. Okay. Tube dislodgement, we told. Some words about eye. What happens? What happens?
So ischemic
Is it only because of
Ischemic-
the, yes, just a second. Is it
No, sir.
only because of pressure or
No,
something?
sir. There are two things. The ischemic optic neuropathy occurs in prone position, even if there is no pressure on the eye. But
Yes.
the other
And
injury,
it is augmented by hypotensive anesthesia, which you usually do.
potential. Yes.
Okay. Usually in spine surgery, you are doing hypotensive anesthesia. So you are already at risk. So you are doing it. And actually, even if you are covering the eyeball, it is like hanging. Okay. It is like a hanging ball. So there are chances of engorgement and conjunctival this edema post-operatively. Okay. So this is ischemic optic neuropathy, and because of hypotensive anesthesia. And actually in some, because this is happening now, we are using it. So transdynamic acid, it is adding insult to injury. Okay. Because microthrombi, which are usually being cleared by the fibrinolytic system, you are blocking it by giving transdynamic acid. Okay. And because they are using it in spine surgery. Okay. Transdynamic acid infusions they are giving. So this is all adding the eye injuries, eye problems. Okay. So in addition to
So
that,
there is another injury of eye. One is the ischemic optic neuropathy. The other one I am not remembering the name, but that was due to the pressure effects on the eye.
okay. So we will just have a look on
Was it something related to retina?
retina, retinal detachment.
No, sir.
No.
Something else. Read it yesterday and I've forgotten it. I'll put it in the group, sir, when I find it.
Okay. So direct pressure on eye and leading to central artery occlusion. Okay. Can lead to
Central artery.
central retinal artery occlusion and ischemic optic neuropathy. Okay. Can occur without any pressure on the globe. That was the word which you were repeating. Okay.
Yes, sir. The ischemic optic neuropathy is not due to the pressure effects, but the other one, the central retinal
Because of pressure.
neuropathy, that is pressure. Yes.
So as I was telling you that there will be edema of all the places, problem with the genitalia, problem with the breast. Okay. So these are the things which are, and actually they are, this was the, there is a table, there is a special about it, but actually this is the one in which you can get the position, like endotracheal tube will be coming through this space, this place, okay? And it is a jelly-like structure, so it is better. It's a good thing. Okay, so special pillows.
So is
And
there a name for it? I think there was a name for it.
I don't know. Neck, I don't know. I'm sorry. I don't know. So, but these are the things they are putting the chest rolls. And if you have maybe in some other article, there is a picture, maybe I will be able to show it. There is a space, there is a hole in the center for the abdomen to hang. Okay. So otherwise, in the normal tables, they put a roll under the chest, they put a roll under the thighs to make the abdomen free. Okay. So because if the abdomen is not free, there will be reduction in the cardiac output if the abdomen is compressed, and similar features of like abdominal hypertension. Okay. So this will occur. Otherwise, okay. So another question is that what is the advantage of prone positioning during ARDS? What is the advantage of prone positioning? What happens? How can you explain, Zishan?
Sir, one mechanism is that the posterior part of the lung, it has more volume, and the more space for oxygenation, for aeration. So when we are putting
Whenever
the
we are
patient in
doing
prone,
prone positioning, we are doing for with reference to ARDS. Okay, it is
Yes, sir.
intermittent. It is not like you are making the patient prone forever. Okay, it
Yes,
is
sir.
called as intermittent prone positioning. Okay,
Yes,
so
sir.
actually it is improving the VQ mismatch in the way that the alveoli which are not perfused and aerated or ventilated in the supine position, they are aerated and gas exchange occur in prone position. So this is the mechanism. And the other thing, of course, as we were telling. Okay, so prone positioning with reference to surgery, prone positioning with reference to ARDS, injuries, problem in the eye, problem in the CNS, and things like that, dislodgement of the tube. Okay, so there are some actually one of the anal procedure, not directly anal, pilonidal sinus. Usually they are doing it in this jackknife position. Okay, so it is also being done for some procedures like that. So as I told you before, that you should be knowing what are the surgeries which are in which special positioning are indicated, physiological effects, problem with reference to joints, problems with reference to nerves, and when you are creating it and when you are reversing it. Okay, so these are the things which should be, as a whole, you should be knowing it. Okay,
So there's also during the bariatric surgery,
bariatric surgery
the
and
legs are apart.
Laparoscopic surgery, they are making, twisting the patient up. And you actually, the basic mechanism I have told you. And then don't forget, the purpose of discussing this positioning separately is that you try to find some points related to positioning in any patient. Okay, because there will be something happening in any patient during this positioning. Okay, so even this positioning is transient or permanent. Okay, there is a problem. Like, for example, I give you a scenario. You are intubating a patient, and then they are pulling the patient a little down. Okay, so at that time a number of complications can occur. Okay, and another thing is that when they are pulling, it is not as much dangerous when they are pushing. Why? Because when they are pushing, actually the spine can hurt, especially at the patient at risk. This has very bad effect on the spine at the junction of atlantoaxial place and the cervical spine. Okay, so cervical spine injury can occur when they are pushing the patient rather than pulling. Of course, you have to support it at that time as well. The tube can dislodge, lines can dislodge, and even during transfer, patient transfer from the trolley to the bed, or from the bed back to the trolley when the surgery is finishing. I have myself removed and the CVP while transferring. So it is something. It's no anesthetist can say that he has not faced it ever in his life. Okay, even, and I tell you something, another thing which I'm during the transfer. So what another thing, what is that is Foley's. There are so many injuries which can occur during the transfer when you don't fix the Foley's catheter. Okay, and that patient will curse you forever, because the structure, there will be urethral injury, there will be structures, and that patient will not be able to be treated till his life, because there will be stricture, they will treat it, and then there will be another stricture. So that's something be very careful about it. So always fix the Foley's catheter. Okay, so I say this, that the care of anesthetist is like care of mother, what a mother gives care. Okay, and the care of surgeon is like care of father, because fathers are usually, exceptions are always there, but fathers will not be as careful or as meticulous as mothers. So in operation theater, actually we think about the patient like a mother. We are not, even you have to think about this thing as well. Okay, so actually the other injuries which can, the only thing which is left is lateral position. I will just, before that, let me see if I miss anything. So there may be dental injury, joints problems, dislodgement. Okay, injury to eye. Yes, this is, I forgot. Even in any position, okay, corneal abrasion is something very dangerous. Okay, if you are not covering, there may be dryness, and any equipment can injure the cornea. So this is one of them. And the thing which,
airway manipulation.
yes, even during airway manipulation, especially it is the case when you are handling a baby. Okay, so you are already under stress, that you are not able to ventilate properly in some cases, or you are not able to intubate, and then you are not worried about the eyes. So this is something which you can damage. Okay, so be very careful about it. And if you are even in supine position, if you are putting the tape and putting gauze or making it a pressure tight, so it has similar effect which you are actually occurring in prone position. Okay, so you see there is post-operative visual loss even documented. Is there any medication which can cause some blurring or eye problem post-operatively? What medication?
These are
Atropine.
disinfectants.
No, atropine. Okay, because atropine cross the blood-brain barrier, and it can cause actually confusion, as well as it will cause a blurring of field. Okay,
So that is due to mydriasis.
yes, it will be transient, but it can occur. Okay, so another actually this is related to neurosurgery, but when they are putting the pins, actually the head is hanging. So even if they are doing it in beach chair position, or if they are doing it in prone position, posterior fossa surgery, the question which I asked in the morning to you. So similarly, this is the point when there are a number of problems can occur, and even when they are removing it, there is you have to be very careful. Okay, so I think I have done number of questions. You see that this is the one I was telling you, that avoid neurological injury. What are the ways to avoid neurological injury during nerve blocks? So one of them is proper landmarks. Okay, then ultrasound, nerve locator. What else? There is one more thing. Injection pressures. Okay, there is a specific syringes, you are monitoring the pressure. So if you are injecting under high pressure, this is something dangerous. Another thing is that the cutting versus non-cutting. Okay. So usually you are using blunt tip. Okay. So, but remember one thing, there is no way, even ultrasound, there is no guarantee that you will totally avoid nerve injury. Okay. And there, in addition to all these things which are in your hand, there will be some patient which will be at risk, like diabetic patient, any patient with any other neurological problem, degenerate neurological problem. Okay. So I have intentionally left lateral position. What are the changes during lateral position?
Ventilatory changes.
Okay, what is that?
One, there is more perfusion in the dependent lung
Mhm.
and lesser perfusion in the non-dependent lung.
In there is difference whether the patient is in awake position, awake, okay, or positive pressure ventilation. There are difference in it. Okay. Because in a lateral position, if the patient is awake, there is not much effect, because ventilation will also be improved. How?
Ventilation will be improved.
Yes.
Ideas.
Anyone?
Sir, either due to VQ mismatch.
No. For example, if patient is awake, so what happens in lateral position? Like you are sleeping.
The lung towards the
Are you having
gravity.
all of us sleep in lateral position? Okay. So do we
Yes.
have a VQ mismatch?
No.
Sir,
Okay.
because
Sorry.
Mm.
You see, this is the sentence which I was telling you. This differs from the awake, spontaneously breathing patient, where both perfusion and ventilation are greatest in the dependent lung. Okay. When you are mechanically ventilating the patient, then air is going more in the non-dependent lung, and blood is more going towards the
Dependent lung.
okay.
Dependent.
Yes. Okay. So when we were discussing, we discussed this brachial plexus more. It is related in lateral position, but it can occur in even in any patient. And when we are making the arms on the right side or on the sides, it can stretch the brachial plexus. So actually, we forgot to discuss about brachial plexus, but usually it in lateral position, especially if you are not covering the axilla, there may be pressure. Okay, so lateral position, they are occurring actually now. The renal surgery, majority of the renal surgery, they are being done in by endoscopy. Okay, but still, if they are doing open pyelolithotomy, this is a lateral position in which they are breaking the bed and they are making some part of the part near the kidneys up. Okay, and some of the, have you heard of PCNL, percutaneous nephrolithotomy? Have
Yes,
you
sir.
heard? Okay, so in
Yes, sir.
this
Ultrasound guided used to usually.
they are doing it in prone position, and but recently
Yes.
they have also started doing it in supine position.
Yes.
They are also doing it in supine position. I have never seen it, but I just discussed it with the urologist, and they are doing it in prone position, in supine position as well. Okay, so I think we have just covered some of the aspects of sitting beach chair position is just like reverse Trendelenburg. So all the problems which are there in reverse Trendelenburg, it can occur. Okay, so I will suggest you to read this very carefully, because in any patient, you have to discuss few words about the positioning. Okay, so you have to carefully place the patient, and you have to be taking care of all the things. The discussion which we have done is not only important from the exam point of view, but it is very important with the practical conduct of anesthesia point of view. Okay, so
Excuse me, sir.
I'm sorry.
Sir, if I'm asking that if it's like that some position is contraindicated in patient due to some reason, or due to some comorbidities, or due to some presenting illness, and the surgeon is saying that I am like satisfied to do my procedure in that position, what will be the answer that we have to give during the exam?
Have you seen politicians discussing? So they are never
Yes,
saying
sir, that
right or wrong. So you will also say that you will do risk versus benefit. Okay.
okay.
So if there is no other possibility, and you have to, if like surgeries, you cannot do it. Like, give you an example. Just give one example.
So like I had a patient of increased cranial pressure, and if they are doing ruptured gallbladder surgery laparoscopically, and in that condition Trendelenburg position is avoided or contraindicated.
Would you like to do would you like to do a laparoscopic cholecystectomy in a patient having neurological problem at that?
No, sir, we can do open as well.
No. You will not do any surgery if the patient is having raised ICP.
Surgeon going to.
Okay, so so you have answer in your comment that again, always you will be doing the risk versus benefit. That's why actually, if this is, I will just, before I finish, I will just show you again, because this is I stressed, I actually took a lot of time to make this document. So I will highly suggest you to have a look on this. Okay, anesthesia plan. Okay, in just a second. For the surgical aspect, you have to do like this: surgical urgency, surgical risk, bleeding risk, patient position required, usual duration, level of incision required, level of anesthesia required, possible anesthesia options, possible analgesia options, potential concerns and complication, specific age group prone for that surgery, and any special equipment required, logistics for that thing. Okay, so if you just, whenever you are discussing any surgery from anesthesia perspective, if you have these things in your mind, your points will not finish, and the time will be finished. Okay, so always whenever they are asking any surgery, just try to see whether it is urgent, whether it is elective. Okay, urgent, there is another word which is that is emergent and urgent. Actually, they are interchangeable. Emergent is the surgery which is to be done within minutes. Okay, and urgent is the surgery usually which is to be done in hours. Can be done, like example is emergency is fetal distress cesarean section. Okay, emergency is acute penetrating injury or acute firearm injury in which the patient is bleeding. If you don't do it, patient will die. Okay, so this is example of emergent surgery. And urgent surgery example is, for example, appendicectomy. Okay, you can do in few hours. Even intestinal obstruction is never emergent surgery. It is usually unless it is bleeding, it is usually urgent. Okay, so similarly, another example of elective versus planned. Actually this cholecystectomy is actually in real sense is not elective, it is planned. Okay, because if you don't do it, the patient will have repeated attacks, and even this stone can come out and block the biliary tract, and the patient will be in jaundice. So that will become an emergency. Okay, so it is never elective, it is actually planned. You can take few weeks to optimize the patient, have acute attack, settle down with the antibiotics and things like that, and then you can do the surgery. But you can, the example of pure example of elective surgery is cosmetic surgery, bariatric surgery, joint replacements. This is the example of pure like liposuction. It is never emergency. Sorry, never even planned. You can delay it forever. Okay, so this you should be knowing. Then surgical risk, that how much is it intermediate risk surgery, high risk surgery, low risk surgery. Okay, so I will suggest you to have a look at it. And similarly, okay, so actually I made this document. I have discussed this in detail. I will highly suggest you to have a look at it, and it will help you a lot in answering your Viva. Okay, it's there in the link. So because we have taken a lot of time today, so thank you very much. We will continue our discussion. Any question? Okay, okay, everyone, thank you, and bye bye.